vinyasa. Or if we're just doing it as a pre-gait activity, which in many cases this first technique anyway, we're going to be doing as a pre-gait activity. I might be working in front of a high-low mat or something like that, but I need something I need you to be able to see what I'm doing. So what I'm going to do is, I'm going to be on actually I'm going to have you hand on the, okay. There you go, rest that hand. So I'm going to be down to his leg. What I'm doing, again, if you're on that side, come on over, so we'll be able to see. So I'm going to have one hand on his quads, and the other hand is going to be on hamstrings. So again, we're talking about stance phase. So when I'm doing the facilitation, I'm increasing tension in my hands. It's going to be when he's in stance. Okay, so what I'm going to have Waqar do is, I'm going to be here. The hand that's on the hamstrings is a little bit higher. So Waqar, what I want you to do is take a step forward with your left foot. And what I'm trying to do is, go ahead, now put it down, and now bring it back, all the way back. Good, forward, and I'll just talk as I'm having him step forward and step back. What I'm trying to get the femur to do is come up over the tibia to get him into that mid-stance position. And I'm also, if he was going into Rikavada because of the weak quads, I'm trying to use this hand up here to give him pressure down through the length of his legs. So like into the floor, saying we need to weight bear, you need to come into mid-stance and get that femur to roll up over. Think of it as like almost like a rocking motion, like the femur needs to come up over the leg in order to come through mid-stance and then terminal stance. And we're saying that's because, this patient doesn't want to do that. He comes into Rikavadam and then takes a step with his less involved side. So again, what you're trying to do, everybody always says when they first practice it, like, where's my pressure? Just think about what's supposed to be happening during that stance phase. So it's here on quads, and then the backhand is on hamstrings. You're not squeezing. You're trying to guide that motion of the femur coming up over the leg, but don't allow him to snap back into that Rikavadam. So I do keep a little tension on the hamstrings and try and prevent that Rikavadam. So you're going to step with your left foot, and now back. And I'm giving him, again, I'm increasing the tension in my hands, and then kind of giving a downward cue, like towards the floor as he comes into that mid-stance. Okay. I'm going to back up. This one I have also done like as a walking activity. It's very difficult for the therapist, not so much for the patient, but if he was walking either with a cane or with, somebody on the other side, you can either, like, I'll put a towel under my knee and kind of scoop my way across the floor. You can sit on a low rolling stool. But it's difficult because you have to slow the patient down enough that you can keep up with them. And once you slow somebody down too much, then you're going to start to see more deviations. Anybody in here, if you tell them to walk at, like, half speed, it's difficult to do, and then you have to compensate somehow. But I'll show you, we'll assume that he can walk. We'll say that you can walk with a cane. We'll say he's a higher functioning patient. So I'll just give you an idea. Again, I'm not going to be able to go more than a few steps, but okay, Waqar, what I want you to do, and again, this is what I always do. I always have the patient start with their less involved side. So I want you to take a step with your left, okay, and now bring your right forward. We're going to say the swing is not an issue. Just step a little more with that. When he gets to here, go ahead and step left. Go ahead and bring it forward. Step left. Bring it forward. Step left. Bring it forward. Okay. Again, if I needed. And especially if you're down there, you're not guarding him. So I would have somebody else guarding him. And he's probably going to be using an assistive device. But you can see why you wouldn't be able to go too far with that particular activity. But again, I do use it for a pre-gait activity. Okay, come on back. Other things you can do, trying to work on graded control of the quads and the hams. Okay, so we just did that activity. And then you can also work on the stance phase activities that we already talked about. You can work at the stairs, which again we're going to do a little bit later. You can work isometrically initially, and then you can work eccentrically, getting him to use his quads to eccentrically lower himself. Stand to sit is a great activity for that. Working concentrically, sit to stand, and also, again, we'll get to working with the stairs. If it's a range of motion issue, we talked about how you could work on ankle range of motion. You could also work in, if it's just a soft tissue issue, you could work with in stride weight bearing or trailing limb with the uninvolved foot forward. So this is, oh, no, I'm sorry. You were right-handed, so it's this foot forward. So put your left foot forward. So you can see how that would, if it's a range of motion issue on for his right ankle, that's going to stretch both his hip flexors as well as his plantar flexors. So it gives you those reaching activities we talked about. So let's say Wakar had, again, he has upper cavatum, but this time it's not a quad issue. And again, it's gonna be easier to figure out with your patients because you're not just pretending that you have these deviations. So if you could again come and face everybody, and this time we're actually going to, I'll do it first just with him just standing still, and then we'll do it as he's walking. Okay, so again, this time we're talking about during stance. His abdominals are not sustaining the contraction that they need, so he's rotating, he's retracting the side of the pelvis. So what I'm going to do is my front hand is going to be on abdominals, and my back hand is going to be on hip extensors. And what I'm going to do, again, when am I going to increase the tension in my hand? When should I start increasing the tension? This is a stance phase issue. So it's as he's, all right, we'll start walking, and you tell me if you can see what we're doing. Well, actually, we won't even do it just standing in one position. So, Wakar, I want you to start with your left foot. Again, why do I want him to start with his left foot? Go ahead, what position does that stop there? What position does that put him in?
Trailing
limb, or stride weight bearing. So now at least he has the opportunity to use what he should use to swing this lower extremity forward. So there's no tension when he's in swing. So go ahead and bring your right foot forward. I'm not doing anything here. It's here that he's starting to rotate. So what I'm going to do is give a little tension. Go ahead and start to take a step with your left. Go ahead, keep walking. So as he loads into stance, I'm increasing the tension through the hand that's on the abdominals as well as the hand that's on the hip extensors. Okay, so let's turn. Okay, abdominals, hip extensors when he gets into stance. So it's here, 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 here. And you notice I'm in the same phase of the gait cycle as he is. You don't want to be like 3 steps behind, or he's stepping with his right, I'm stepping with my left. So let's turn around and try that one more time. I'll do it on the other side. So he's now left hemi, here and here. Okay, you're going to step with your right foot first. So I'm giving the pressure here. I grade up, I grade down. I grade up, I grade down. I'm just keeping them in position as he goes into swing. Go ahead and turn. Here and here. So it's here that I grade up. He's obviously walking without any deviation, so it's hard to, you're just really learning the hand placements now. When you see it with your patients, it'll make more sense. Yes.
The hand that's on his abdominals is to help bring the hip back?
It's to
Or
keep
to
it neutral.
stop it from rotating?
And it's very hard, as long as you learn the hand placement, it's hard to, he's not retracting. So it's hard to see, like, why is your hand there? It's for the patient who's coming into stance and the abdominals just shut off, they're not doing what they need to do, they start retracting, and that's causing them to go into
Oh, so normally it goes
Rickenbacker.
back?
No, you don't want it, you want it to stay neutral.
Well,
you
for
don't
the
want it to
patient, the
rotate.
patient normally presents leaving that side behind, or bring the
They
seat
could,
on?
it's not what they do normally, I just picked out some deviations that I see that are common.
Okay,
So the first deviation we're talking about is that they're going into January cravati. We said, number one, they could be doing that because their quads are weak, so they're snapping back because they want to rely on their ligaments to hold them up. The second reason could be because what's supposed to happen in the trunk is not happening. So maybe they're coming into stance and they're rotating back and doing this, and it's causing them to go into recurvatum. But it's really because of what's going on with the trunk. So I'm using my front
So
hand to
just
facilitate abdominals.
sensory for them to.
Yes, it's a tactile cue to say, nope, ab, you gotta keep working.
And then
Yeah.
the one on the glute?
Is same idea, it's saying hip extensors, you gotta keep working.
Okay.
Because a lot of times when they start to rotate, they kind of fall
Flex.
apart at the hip extensors and they start to flex forward.
Okay,
So again, if you learn the hand placement, that's the important piece. Your patient will tell you exactly where they're weak, you're gonna know exactly where you need to put your hands, because they're presenting you with what the problem is.
All right.
You work on it with each other, that piece is more challenging because you don't have these deviations, but.
Patients can have this trunk retraction deviation without having recurvatum also.
Absolutely.
That could be a deviation in and of itself. That's not causing a recurvatum.
Yes, that's true. They can have any combination of these things. And then I just want you to right now keep that we're working in stance phase in your mind, because in a few minutes we're going to switch over to swing phase. They could also retract and do some strange things during swing phase, and your hand placement is going to be different because it's a different phase of the gait cycle as far as what you're trying to accomplish. So when we get there. If you could just keep them the patient, that would be great.
Sure.
Okay, so that is working on the abdominals. The third, or the next common one that I see is Trendelenburg. Now I know that sometimes this is confusing to people. Does everybody know what a Trendelenburg is? So this is different than what we were talking about before when I was saying the pelvis needs to drop a little bit prior to swing. This is, as the patient loads onto that weak side, if there's weakness here, this hip is gonna, I always describe it, this hip is dropping, but this hip is, the abductors are weak, so that's kind of what it looks like. And then to compensate, in many cases, the patient's going to laterally flex their trunk because they want to keep their mass over their base of support. So instead of, if this starts to do that, instead of collapsing that way, a lot of times what they do is flex to that side. So again, we're saying in many cases, what is weak there? Glute med, right, the abductors, hip abductors, so we're gonna address that. So, again, if you were gonna do some of the stance phase activities we did here, this is my weak side, what would you have me do with my left leg to address working on these abductors during stance? Move it laterally, right, so if I abduct my strong leg, that's gonna put increased demand on the abductors on the stance side. So that's one of the things you could do. And then you can also do what I'll show you right now while we walk. So if the abductors are weak, again, we're assuming, you might need an assistive device or whatever it is on that side. You could be walking with a rolling walker, whatever it might be. So here I'm gonna put one hand over here, which is nice because it's kind of the position you would guard him in anyway. But this hand is actually gonna be where I can get his glute med, his abductors. So what I would like you to do, again, we're going to start with his left foot forward first. So that puts him in that trailing limb. And now go ahead and step right. And now I'm increasing the tension right here. 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 So as he loads onto that extremity, that's when I'm increasing the tension. Again, because we're saying that this patient is doing this as soon as he gets into stance phase. So I'll show you on this side. Again, this hand, I'm not facilitating anything on this side. I'm really just guarding, kind of using it as like a counter pressure. This hand is here, so you want to be on muscle. So go ahead and step with your left foot. So it's here, here, and I want to be in the same phase of the gait cycle. Here, here. Okay?
Are you approximating medially?
It's not, you don't want to push him over. What I'm trying to do is give a cue to the abductors that they have to keep working when they get into that mid-stance phase so that he's not just letting them go and, again, if he's walking this well, chances are it's not like he has 0 out of 5 hip abduction strength. So it's a lot of times it's, again, those muscles aren't turning on when they need to turn on during the appropriate phase of the gait cycle, or they're not sustaining that contraction. So what I'm trying to do is address it in a functional way during the appropriate phase of the gait cycle. So you can also do, your traditional hip abductor strengthening that I'm sure you've learned about, but these are 2 ways you could do it. Again, in standing, having him strong leg out to the side and back is going to make these abductors work. And then again, during the gait cycle, you can also address it. And again, the goal is hands off. If he can, nobody's going to go home with the patient facilitating the abductors every time, whenever he has to get up and go to the bathroom. That's just not realistic and it doesn't make any sense. But what you're trying to do is just give that tactile cue, bless you, to tell the muscle when it needs to work at what point. All right, thank you very much. Okay, so when I want you to break up and practice